Good evening, all. Presenting a case of Raman, 57-year-old male. Is a manual laborer from Changarangulam. Presenting complaints. He complains of pain, double vision, and progressive protrusion of left eye for the past 2 weeks. History of present illness. The patient was apparently asymptomatic 2 weeks back. He then developed pain in the left eye, dull aching, more in the junction between nose and left eye. It was moderate in intensity. It was radiating to the left side of the head with no exacerbating or relieving factors. After 2 days, he noticed a fullness below the left eyebrow. He then developed a double vision, which was intermittent initially, later become constant, which was more on looking straight and superiorly, which disappears on closing one eye. And after 3 days, he noticed a protrusion of the left eye, insidious in onset, which was progressive. History of recurrent headache and nasal obstruction was present. There were no history of defective vision or redness, no history of postural variation, no history of variation with sneezing, straining, or coughing, no history of recent loss of weight or loss of appetite, no history of fever, no history of heat or cold intolerance, increased sweating, tremor, or palpitation. Coming into past history, no history of trauma or sinonasal surgeries. There were no history of diabetes, mellitus, hypertension.
Are you all seeing the screen?
No, even I am not able to see the presentation.
Even I am not. Anu, the PowerPoint is not shared actually.
Okay.
I thought it's my problem. Yeah. Initially it was. Right now, when we are presenting, it was not. Yes.
Now it's fine, madam.
No, not there. Make it full screen.
Okay, madam.
Start from the beginning.
Okay, madam. Okay. Presenting a case of Raman, 57-year-old male. He is a manual laborer from Changarangulam. Presenting complaints, pain, double vision, and progressive protrusion of left eye for the past 2 weeks. History of present illness. Patient was asymptomatic 2 weeks back, developed pain in the left eye, which was dull aching, more in the junction between nose and left eye. It is moderate in intensity, radiating to left side of the head with no exacerbating or relieving factors. After 2 days, he noticed fullness below the left eyebrow. He then developed a double vision, which was intermittent initially, later become constant, more on looking straight and superiorly, which disappears on closing one eye. After 3 days, he noticed a protrusion of the left eye, which was insidious in onset, progressive. History of recurrent headache and nasal obstruction was present. There were no history of defective vision or redness, no history of postural variation, no variation with sneezing, straining, or coughing. No history of recent weight loss or loss of appetite, no history of fever, no history of heat or cold intolerance, no history of increased sweating, tremor, or palpitation. Coming to past history, there were no history of trauma or sinonasal surgeries, no history of diabetes mellitus, hypertension, cardiac disease, no history of tuberculosis or contact with the tuberculosis, no history of any malignancies. Coming to personal history, he consumes a mixed diet with regular bowel and bladder habits. Family history, there were no history of any tuberculosis or malignancies. Drug history, he was not on any regular medications. And coming to general examination, the patient was conscious, cooperative, and oriented, moderately built and nourished, no pallor, icterus, cyanosis, clubbing, no generalized lymphadenopathy or pedal edema, no thyroid swelling. ENT examination, there was deviation of nasal septum. Ear and throat examination was normal. On general examination, pulse rate was 80 per minute with regular rhythm, normal volume and character, no vesical thickening. All peripheral pulsations are felt bilaterally and equally. On blood pressure was 132 by 80 mm of mercury in the right upper limb sitting position. Skin, hair and nails are normal. Systemic examination, respiratory system was within normal limit except for a DNS. GAT and cardiovascular system examination was within normal limit. And central nervous system examination, higher mental functions are normal. Cranial nerve examination, cranial nerve 1, no anosmia. 2, 3, 4, 6 dealt with ocular examination. Other cranial nerve examinations was within normal limit. Motor system examination, bulk, tone and power was normal. Sensory system was within normal limit. Skull and spine normal. No signs of meningeal irritation, no cerebellar sign. And coming to ocular examination, the patient's best corrected visual acuity was 6/6 both eye with a near vision, N6 both eye, and color vision was normal. Coming to ocular examination, head posture was erect, and on inspection, there was a fullness in the area below left eyebrows with a proptosis, which was forward, downward, and laterally. No periocular pigmentation, visible pulsation, postural variation, engorged veins, lid retraction, lid lag or lag of thermos. No change with Valsalva maneuver or straining. Proptosis was non-compressible, non-reducible. No thrill or pulsation felt. No resistance to retropulsion. On auscultation, no bruit. Proptosis measurement was done and noticed left eye there was a forward protrusion of 11 millimeter with a vertical dystopia of 5 millimeter and horizontal dystopia of 21 millimeter, suggestive of severe eccentric proptosis with infralateral dystopia of left eye. And there was film swelling was palpated 1 centimeter into 0.5 centimeter in the supromedial aspect of the left eye above the attachment of medial palpebral ligament with a well-defined inferior, medial and lateral margins and ill-defined superior margin. It was hard to insinuate finger between the superior margin of the orbit and the swelling. And the swelling was immobile. Skin over the swelling was normal, not adherent to the underlying structure, tenderness present, no raised temperature. And extraocular movements, there were limitation of elevation and adduction of left eye. And anterior segment examination was normal within normal limit right eye, left eye, lid anagnesa, swelling on the supromedial aspect of the left eye, which was as described, with an eccentric proptosis with infralateral dystopia, no lag of thermos, no lid retraction, lid lag, no other signs of thyroid eye disease, regurgitation on pressure, and lacrimal apparent system was negative. In conjunctiva, there were no conjunctival or circumcorneal congestion, no chemosis, no dilated episcleral vessels. Sclera was normal, and cornea was normal in size, shape, and transparency. Sensations were normal, no evidence of any exposure therapy. Anterior chamber with normal depth with Van Hel's grade 4, no cells or prayer. Iris was normal in color and pattern, no nodules seen. Pupil, it was round, 2 millimeter, direct and consensual reflexes are brisk and no evidence of RAPD. Lens, nucleus pleurosis grade 1. Fundus examination by using distant indirect ophthalmoscopy, indirect ophthalmoscopy and anti-D examination was within normal limit both eye with no evidence of optic nerve compression or no evidence of any choroidal spot. And intraocular pressure
You're going
measurement.
very fast. Slow down a bit.
Okay, madam. Okay. Intraocular pressure examination using Goldman applanation tonometry was 14 millimeter of mercury both eye. Differential tonometry was negative. Gonioscopy showed grade 3 open angles in all 4 quadrants with no blood-tinged lens canal. Visual field was normal. Diplopia charting done at 1 meter distance with the red in front of right eye showed binocular crossed diplopia with a maximum separation on dextroversion and dextro elevation. Post-duction test was positive. Lacrimal system examination was within normal limit. Roplas negative, and dry eye evaluation showed no evidence of dry eye. Coming to summary, 57-year-old male with no non-comorbidities presented with a pain, double vision, protrusion of left eye for the past 2 weeks, which was progressive. General and systemic examination was within normal limit, except for a deviation of nasal septum to right. And on ocular examination, his best corrected visual acuity was 6/6, near vision N6, and color vision normal both eye. Left eye showed a severe eccentric proptosis with infralateral dystopia associated with a film swelling in the supromedial aspect of left eye with a tenderness. Extraocular movements, there was elevation and adduction restriction of left eye with the post-duction test positive. Diagnosis: severe unilateral eccentric proptosis with the infralateral dystopia of left eye with a firm mass in the supromedial aspect.
Can you go back to the summary?
Yes, madam.
So what would be your differentials of proptosis with pain?
The different since there is pain, it could be an inflammatory condition, it could be an infective condition, or it could be a malignancy with the compression of the nerve or bone. Pain can be due to any acute pressure effect, or it can be any rupture of the dermoid cyst or any parasitic cyst.
So inflammation.
It could be inflammation. One differential type could be inflammation. It could be any infection. It could be any malignancy with the compression of the nerve.
What was the type of the pain the patient described?
Patient was having a dull aching pain,
so
which was constant.
So would that change your differential?
Differential, since it is a dull aching pain, It could be due to compression effect.
Okay. Then what about the age? Would age give a clue?
Since he is a 57-year-old
Mhm.
male, it could be an inflammatory condition like idiopathic orbital inflammation, or it could be malignancy.
Very good. Madam, you want to ask any questions?
No, there is a mass and there is pain and diplopia. So, how do you localize that thing?
Since there is a
That if it is an inflammatory condition, which inflammatory condition can produce diplopia along with pain and you feeling a mass? Is there any specific inflammation which can affect the muscles? You were talking about
orbital
ruptured.
myositis.
Which one?
Orbital myositis.
Orbital myositis. You mean to say that it's a non-specific orbital inflammation, mainly involving the
Orbital.
muscle, myositic type. Is
Yes,
that what
madam.
you're trying? That is one possibility where you can get both pain and diplopia along with a mass sometimes. Any
Yes,
other
madam.
condition where muscle can be affected if it is an infected? Because the onset, according to you, it is an insidious onset, right?
Yes,
Maybe a
madam.
subacute type of inflammation.
Yes, madam.
So in each other condition, you can get extraocular muscle involvement and signs of inflammation. Is there any cystic lesion which can affect the extraocular muscles and present with a mass later, which can rupture sometimes?
Parasitic cyst or dermoid cyst.
Which parasitic cyst? Myocystis.
Cystic.
That can also produce these kind of symptoms, but there is no congestion here.
Yes, madam. No congestion, madam.
So when diplopia and motility restriction are important clinical symptoms, as you presented in this case, you have to think on those lines also.
Yes, madam.
Anything else? Ravija?
Yes. So apart from firm and tenderness, did you examine anything else for the mass? You said it has a firm
Margins.
swelling with tenderness. Anything else?
Yes. There were no other signs of inflammation. The transillumination test was negative since it is a firm mass. Then adherence to the skin, it was not adherent to the skin, and the margins except the superior border was able to palpate, and we cannot insert fingers between the superior border and the mass.
So when it is a ill-defined lesion where you cannot insinuate
There
your
were no
fingers.
local rise of temperature.
No. When it is a diffuse kind of mass, will you be able to do transillumination? Where is that test relevant?
In a cystic mass only, madam.
Here it is not relevant in
No,
transillumination.
yes.
But there are certain other tests which Dr. Revita is asking, which are significant here. Any postural variation or any other test which we will do?
Valsalva. There is no change in the mass in Valsalva.
Yeah.
Or on bending forward.
So what are you trying to check by doing that test?
Orbital varices.
Varices and
caroticocavernous fistula also can.
Does it produce this kind of a Valsalva's positivity?
It produces a pulsatile proptosis in CCF. Orbital varices and in encapsul or metadocil can also on bending forward, it can also increase the swelling.
That will have transmitted pulsations as well.
Yes, yes.
So you have to look for pulsations along with the swelling.
Yes, there were no pulsations.
So How did you manage this patient further? Any investigations were done for the patient?
The patient was, since the patient had nasal obstruction symptoms and he had headache, so we sent a ENT consultation. From the ENT department, they did diagnostic nasal endoscopy. So they found a mass in the upper part of the middle meatus, and they did biopsy, and it came out to be, and CECT was advised. And in CECT, this an amplified heterogeneously enhancing lesion extraconally abutting the superior oblique muscle with the erosion of roof of the left orbit and extension into frontal sinus superiorly, and also anterior ethmoidal sinus medially was found.
So you stop here, and before going to the biopsy report, you stop here. With
Yes,
the
madam.
imaging, we can discuss the imaging, and
Yes,
then only
madam.
we'll go to the final diagnosis. So
Yes,
Ravijay,
madam.
continue.
Yes. Can you go to the next slide? Okay. So there is erosion of the which wall?
Medial wall and also roof of the orbit extending in the frontal sinus, and erosion of the medial wall with intranasal extension.
So is this a mass which is primarily arising from sinus and going to orbit, or you feel it is an orbital mass which is going into sinus?
Can be an orbital mass go into the sinus, or
Can be either way.
either way, madam.
Either way, but more
How do you know?
more likely these are usually sinus lesions which are extending into
Yes.
the orbit more
Orbit.
commonly.
Okay.
So what are the characteristics of the lesion? Can you describe this lesion radiologically?
It is a heterogeneous lesion with which is with irregular borders, and the margins are indistinct with the erosion of the bone.
Does it
Can you
enhance?
do a
You said you did a CCT scan, right?
Yes, ma'am.
So is it enhancing on contrast or not?
Enhancing, madam.
What do you understand from that? If there is enhancement, how do you correlate that clinically? What do you think it is? Which all in which all lesions you will get such an enhancement? Is it moderately enhancing or very much enhancing? So that will tell you a lot of clues about your diagnosis.
We need to compare with the muscle to see the enhancement. If it is highly vascular, it is
Yes.
intensely enhanced.
Mm-hmm. So in your clinical examination, you are more in favor of a diagnosis of an inflammatory lesion. From your history and your examination findings, you were thinking in terms of an inflammatory lesion, which can be a specific inflammation or a non-specific inflammation. Now you're doing an imaging and you're looking for a second, more confirmatory diagnosis. So is it after seeing the imaging, do you think that it is a lesion which is a cyst that is ruptured and producing inflammation, or is it something which is a diffuse enhancing lesion involving the sinus and the orbit, which is more probable?
It is a diffusely enhancing lesion involving the sinus and the orbit rather than a ruptured cyst.
Any ruptured cyst, because we are not seeing any ruptured cyst or any other cystic wall here. It's a diffusely enhancing and invading lesion with some secondary bone changes also. Right?
Yes, madam.
So we'll move more towards a neoplastic lesion, right?
Yes, madam. Yes, madam.
So that is how you do the clinical radiological correlation. So in any case of proptosis, we have to do that. So clinically, with your history, examination, and some whatever findings you are getting, you will get some kind of a clinical diagnosis. Now, for more confirmation, we will be moving to other investigations, and that will help you decide how closer you are to the definitive diagnosis. So you are now. Do you have any other more specific diagnosis to add?
Histopathology.
Imaging. Histopathology, we will come to that later. With the radiology, what will you do? What will you confirm? Is it inflammatory? Again, inflammatory.
You can do a.
Or is it neoplastic? Just a neoplastic, malignant tumor. Is it possible? Just think about it.
Spiral CT can differentiate.
Whatever information available with you right now, what do you think it is? What do you think it is?
It could be a malignancy with the erosion of the walls. So it looks like a high-grade malignancy.
It can be a malignancy also, right?
Or
Yes,
any
madam.
other differentials?
Can it be any other differential?
It could.
If you think beyond inflammation, can it be because the sinus and the orbit is involved and it is heterogeneous? Middle meatus is also involved. So, anything else you have to think of? Which infection? Which infection can present like this?
Mucormycosis.
Fungal rhino orbital sino-orbital disease. That is also a possibility, right?
Yes, madam.
Can it have an insidious onset? Yes.
Yes, ma'am.
Age is appropriate? Yes.
Yes.
Clinical findings can be possible, right?
Yes,
and the radiology is also suggestive. Yes, so we can't rule out that possibility also at this point.
Yes, ma'am.
So it can be inflammatory, it can be a malignant lesion, or it can be an infective fungal etiology. Anything more to add, Sanjay?
No, that's so. These three differentials you keep in mind with the CT find.
Yes, madam.
So we are ruling out what are things we are ruling out by doing this. We are excluding the possibility of a thyroid disease, excluding the possibility of a myositis. We are excluding the possibility of an orbital cyst or a parasitic cyst or whatever, and we are also excluding any benign lesions. Any well circumscribed benign lesions we are excluding. So we are coming more closer to a differential with a priority. Priority in this. Maybe it is a fungal sino-orbital disease, maybe it's a malignant disease which is invading into the sinus, or maybe it is an inflammatory disease, non-specific, which will be our last diagnosis, right?
Yes,
Now, Raksha?
You can go ahead.
So, what did you do? The biopsy you have done. The ENT people have taken a biopsy.
Yes, madam.
And the histopathology is available.
Histopathology showed a high-grade non-Hodgkin lymphoma, that is B cell type with DLBCL, that is diffuse large B cell lymphoma. And the immunohistochemistry is CD20, CD3, CD5, BCL2, and BCL6 positive.
So is it a little surprising, Ravija?
Yeah, yes, it is.
It is. The history, the examination, and the final histopathology are not at all in tune with each other.
Yes, yes. There was no conjunctival lesion?
No conjunctival lesion, no salmon.
No patch, nothing?
Nothing was there.
Also, the bone erosion which you are seeing is also not something which we usually see with lymphoma. With lymphoma, it's a chronicity. Usually, it will get molded with the bone contour.
Yes.
That is what we usually see. So that is not there. Instead, a little bit of erosion has been noted. So those findings are not actually the one which we usually diagnose as lymphoma or lymphoproliferative disorder. The spectrum can range from a benign hyperplasia to a highly malignant lesion, but unfortunately, this imaging and the diagnosis somehow it is not correlating to me.
Even the tenderness lymphoma patients usually do not complain of.
They will never complain, and diplopia also. Whenever it's a superior elevation deficit, diplopia, usually patients will not recognize. If it is an inferior gaze persistent problem, they usually will complain. But when it is a superior gaze persistent problem, they usually won't complain. So the diplopia, the pain, all these are contradictory or atypical to this kind of a diagnosis. I was more thinking in terms of a fungal, invasive fungal disease than an inflammatory or a malignant disease with the history.
Yes, or a mucosal
Yeah,
mucosal
yeah. So this is a little bit of, I don't know.
It is a surprising, but orbit is a Pandora's box.
Yeah. So only by doing the definitive histopathology, you can reach the definitive diagnosis.
Yes, ma'am.
Continue discussion. Great.
So any other diagnostic test was done an orbital lesion for the orbital lesion, or the patient was treated on basis of endoscopic biopsy?
Patient was sent for higher center for further management, that is MBR Cancer Center, and from there they took PET scan and staging, and from which patient was managed with chemotherapy with 6 drugs, 6 cycles followed by radiotherapy, and patient became symptomatically better and proptosis decreased.
So was it? Okay.
Yes, you go ahead. You go ahead, madam.
No, my question was it confined to the orbit or was it a part of a systemic disease?
No, it was confined to orbit, madam. The PET scan was taken and it was staged as
In which type of orbital lymphomas there can be a systemic element? Need not be always orbital. These patients are vulnerable for systemic involvement also, especially when it is a bilateral disease. Here in this particular patient, it's a unilateral involvement, but sometimes it can be bilateral disease. And in those cases, systemic NHL is also a possibility. We have to keep that in mind.
Okay, ma'am.
So for lymphomas that are isolated to the orbit, what would be the management of choice?
If it isolated to orbit, can
Like this patient of yours.
Can be surgical management if it is isolated to orbit and chemotherapy.
We will do surgical. Do you think that we can completely remove this tumor?
If it is not low-grade malignancy, otherwise chemotherapy and radiotherapy, radiation.
Yes, radiation would be the management of choice.
Management of choice.
Orbital, only isolated orbital lymphomas. Madam, anything else?
Yeah. So then just forget about the lymphoproliferative. Suppose if it is a fungal disease in your endoscopic because it is clinical picture is more in favor of such a diagnosis also. If we will assume that this patient had lymphoproliferative, but if it is fungal, what will be the line of management?
Antifungals.
Oh, topical.
Systemic as well as retrobulbar
injections. How do you decide the urgency of management? If you are doing in this particular case, we are doing only an incisional biopsy, right, for the diagnosis. Sometimes you may have to, as you were saying, you may have to do an excisional biopsy. The whole tumor has to be removed. But in this particular case, it is not possible. We are only doing a diagnostic biopsy and then we are deciding the management. Here, there are certain situations where there is an urgency in management. So, how these orbital tumors can affect your vision?
Tumor can cause compression.
Any tumor, not this one. Any tumor. In any case of proptosis, what are you concerned about vision? What are the clinical signs you will look for to assess the severity of that lesion and the vision, the importance of vision loss?
For color vision, RAPD, and patient can have exposure keratopathy, optic nerve compression, severe compression causing disc edema or hemorrhages, and choroidal folds.
So what is the most important when you see a case of proptosis here? What is the important clinical test?
Signs of compression.
What sign? That is in your examination, which sign is the
Compressive
most
optic
important?
compressive RAPD, madam. Compressive optic
Your
neuropathy.
pupillary reaction.
Reaction.
Pupillary reaction. If there is a relative apparent pupillary defect in bilateral disease, you may not get it relative sometimes, but pupillary reactions, if it is abnormal, along with that, if there is a red desaturation, you need not get a defective color vision. Initially, there will be only
Red desaturation.
red desaturation, and along with that, you look at the optic disc, and if there is an edema, what are the other optic disc changes you may get in a case of proptosis?
Can be occlusion, vessel wall
What
occlusion, retinal vein or artery occlusion.
And those are rare. No? What initially you will see is chronic optic nerve compression. What are the signs? What are the lesions which can compress the optic nerve? Forget about the lymphoma thing. I'm talking about other compressive lesions of the optic nerve, tumors.
Yes, madam.
So there, what will be the clinical manifestation you will see?
Any intracorneal or lesion or extracorneal lesion can compress the optic nerve. Mostly intracorneal lesions. Patient presented with vision drop, red desaturation, or like
on the optic disc, what will you see if there is a chronic compression?
Optic atrophy.
Compression. Yeah, there can be optic atrophy, maybe temporal pallor sometimes. Then what else? Typically, you will look for certain findings. No?
Optociliary shunt.
Yes, look for shunt vessels, and that also will tell you that something has been compressing the optic nerve for a long time. Then, occasionally, you may get a venous occlusion or a central artery occlusion. All these can happen depending on the location and the timing and all those things. But usually, a pale disc or a temporal pallor or a optic nerve sheath, or shunt vessels, or a disc edema. These are the things which you will look for. Anything, any additional thing? If it is a beta bulbar tumor, what do you look for in the posterior pole specifically? Which can also affect vision. Something compressing from behind.
Resistance to retropulsion.
That is your examination. Again, now we are discussing about
choroidal folds.
Yes, choroidal folds. So you specifically look for these findings when you are examining. If you are seeing an abnormal pupillary reaction, if you are seeing if the patient is having a red desaturation, if there is an optic disc edema, or if there is an opticociliary shunt vessels, or if there are choroidal folds, all these are vision-threatening conditions. So in those cases, the disease may be a little threatening the vision, and then your diagnosis and management has to be in a more urgent manner rather than in a slow-growing orbital, benign orbital tumor, where there is you can have some time to manage, plan, and then do the surgery and all. But here in these situations, it is more of an urgency. Okay. And about the exposure lag of thalmus, we are repeatedly saying there is no lag of thalmus. Why that is significant?
Exposure keratopathy, if there is a lack of somehow, there is a high chance of exposure keratopathy.
So look for exposure keratopathy and a lack of thalmus. Look for pupillary abnormalities. Look for movement restrictions and look for fundus findings. All these are important in any case of proptosis. Now, just giving you an example or a clinical situation, the tumor which you are seeing on the supromedial aspect, right? Just believe that it is on the supratemporal aspect. Whatever lesion you are seeing in this X-ray picture, no?
Yes,
suppose if it is on the supratemporal, upper outer quadrant.
It can be a lacrimal gland.
So your primary diagnosis will be related to lacrimal gland. So if it is a similar consistency, heterogeneous, mass, irregular, broad waist and all, with bone erosion and all, what is the most common malignancy that can affect the lacrimal gland?
Most common is pleomorphic adenoma.
Pleomorphic adenoma is usually
it's a benign condition.
It's a benign condition. Usually it is well encapsulated most of the time. Occasionally it can be, but which is the malignant lesion that we are all... which one?
Adenocystic carcinoma.
Adenocystic carcinoma. Does adenocystic carcinoma can present with pain?
It can present with pain, madam. No.
Why?
Nerve.
Perineural invasion.
Perineural and...
So that is also one clinical picture I was thinking. When if it was on the other side, we would have made a diagnosis or at least we have suspected a diagnosis of lacrimal gland malignancy. That is also very important diagnosis. So there also we will do only an excision biopsy and confirmation, and then treatment is different. Chemo. Anything else, Rebecca?
No, I think you have discussed all the relevant points.
Yes, some more time.
Okay. Any questions from the participants?
Sujata? In this particular case, I think there is a little bit of contradiction. Your symptoms, your diagnosis and final diagnosis and the radiology, they do not actually go hand in hand. And that is how the challenge in orbital diagnosis. So it can be anything. But with all these, this is how we reach a diagnosis. Whether it is a benign or malignant or cystic lesion or whether it is a ruptured system, whatever, they can produce like the inflammation. But later on, when you do the radiology, you will get a clinical radiological correlation. And from there, you go for the histopathology. And histopathology, you may get a lot of histopathological surprises. If you do a radiotherapy for this patient in orbital lymphomas, what are the complications these patients can develop later on?
Radiation retinopathy.
More common?
Cataract.
Yes, you can. From anterior to posterior, you do. Plus, what you can get
injury to injury to the lacrimal gland, dry eye.
Dry eyes are very common. Ocular surface disease and dry eyes are very common following orbital radiation. Head and neck radiation, in any head and neck radiation it can occur, but in orbital radiation it is the probability is higher. So these patients need that kind of a protection. Is there any chance for recurrence in orbital lymphomas? What is the prognosis? Is it good or bad or worse?
Low-grade lymphomas can have good prognosis. High-grade lymphomas like DLBCL have poor prognosis.
Poor prognosis, but still it has a less prognosis compared to the low-grade lymphomas. But if it is confined to orbit, usually they have a very good recovery, unlike the systemic one. But in bilateral disease, when it is bilateral orbital lymphoma, there is a possibility of recurrence and also there is a possibility of systemic manifestations later on. These patients need continuous follow-up for longer periods. That's about lymphoproliferative. But when you say you cannot make a diagnosis of lymphoma as such, you have to, it's only a lymphoproliferative disease, and the spectrum can range from benign hyperplasia to high-grade lymphoma. So it's a range of manifestations, and the histopathology and immunohistochemistry for typing is very, very important. That is why the importance of taking a biopsy in these cases. Usually what happens is these lymphomas do respond to steroids, systemic steroids. So one of our diagnoses was non-specific orbital inflammatory disease, right? So there, what is the treatment? What is the treatment you should give?
Steroids.
Systemic steroids. So if you give systemic steroids to a patient with lymphoproliferative, again there will be some response. The disease do respond. So that you can consider it as an improvement, and then they will go on giving steroids and the disease will go on recurring. But when it is recurring, you should at least make a modification of your diagnosis. You should stop the steroids. And if you are taking a biopsy, you should always make sure that you stop the systemic steroids for a minimum of 2 to 3 weeks. Then only you take the biopsy. Also, when you go for the biopsy, you have to go to the central or the core part of the lesion. Otherwise, in this, whatever any lesion surrounding, there will be an area of inflammation. So you will only get the inflammatory tissues if you are taking the biopsy from the superficial parts. So you always go into the epicenter of the lesion and try to get a deep core or a cone of very good tissue. Otherwise, the biopsy results will be always inconfirmation. We will never get a confirmation regarding the diagnosis. So, in lymphoproliferative diseases, if you treat them with systemic steroids, there will be some response, and that response is always suboptimal. And if that response, if the patient's disease is recurring, you should always stop and do a biopsy. Whether in a non-specific orbital inflammation diagnosis, if the response is inadequate, then also you have to go for a biopsy. Sometimes you think it is not specific, but it is always a diagnosis of exclusion. After excluding all other specific inflammatory conditions only, you can reach the diagnosis of a non-specific inflammation. So if there is a specific one, we have to get a biopsy. So if it is not showing the improvement that you anticipate in a case of orbital inflammatory disease, then again a biopsy has to be done. And whenever you are doing the biopsy, you have to stop the systemic steroid for a minimum of 2 to 3 weeks. Okay.
So, Reena, can I ask something?
Yeah.
Reena, this is rapid progression in this disease over 10 to in 2 weeks. The prognosis increased so much. Is it common in?
It's not common in lymphoma. That is my experience. I have never seen such a, unless it is
Dr. Ravija,
compromised or something.
Yes, that is what we were discussing. Even the radiological and the clinical history, they are not matching with the diagnosis. But ultimately, whatever is there on the histopatho, we have to treat accordingly.
and it
So
responded also.
it will not be a classical case of lymphoma.
Yeah.
Classical cases of lymphoma would not present like this. They would have some dilated vessels in the conjunctiva with the salmon patch. Especially these superior lesions, they tend to have conjunctival lesions as well.
Yeah. Conical lymphoma is almost always associated with this. So we can even go through that area and take the biopsy. And sinus invasion is also very rare in lymphoma. I have never seen. And another thing is that if the patient is immunocompromised, maybe there is a rapid progression and this kind of. Otherwise, I don't in a normal healthy person, otherwise healthy person, this kind of a history, it is not matching our concept of lymphoproliferative diagnosis. It's more like a fungal basic. But if the patient responded to the treatment, then we cannot question it. Otherwise, I would recheck the diagnosis.
And actually, the location it's related to the sinus, so that they can take a biopsy easily. If it was somewhere else, it is not easy. That also helped maybe in the diagnosis.
Do you have any post-treatment photographs with you?
Now, I have not included in the slide, madam.
Okay, but you have.
I have it.
And his proptosis is reduced.
It's reduced, madam.
Okay. We are on the right track only, but it is an atypical case of lymphoproliferative. The symptoms, signs, everything is a little bit of contradictory. But that is not your problem. We are just discussing the case. And what is this diplopia due to? Why do you think? What do you think that the cause for this diplopia in this particular case? Because muscles are not seem to be affected in the imaging. Whatever pictures you have shown, I have not
abutting the muscle.
Abutting which muscle? Superior oblique.
Superior oblique there.
Is that the reason for this? So, what are the usual causes for ophthalmoplegia in orbital tumors?
Can be either a tumor abutting and or due to nerve
Abutting means
paralysis,
mechanical obstruction.
Mechanical obstruction and fibrosis later. In case of
Fibrosis, in which condition you will get? In this particular disease, this is a diffuse infiltrative. So it can infiltrate into the muscle also. See, infiltration is a different mechanism. Mechanical obstruction or mechanical limitation is another mechanism. And you can also have neurological causes. Right?
Okay, madam.
So in which condition you will get infiltration and fibrosis as the reason for restriction of motility? Common conditions.
No specific orbital inflammation.
In any proptosis, if there is limitation, and if you are seeing a mass, maybe there is mechanical obstruction. If there is no mass also, sometimes there will be motility restriction. So how do you infer that? What is your diagnostic criteria for that? Why this limitation in this particular case? If it is a thyroid disease, what is the cause for that?
Fibrosis.
Fibrosis, is it from the beginning?
Initially, there is swelling of the muscle due to increased glycosaminoglycans and imbibition of more
that is theory. I am asking you the clinical examination part.
Restrictive and paralytic can be differentiated by using.
Do you think that paralytic can occur in thyroid disease?
No, it is restrictive. Thyroid disease, it is
restrictive. FTT will be positive. In your examination, you said FTT is positive in this particular case. I don't know how. Yes. So does that mean that the disease has infiltrated into the muscle?
It can be due to infiltration.
Or is it mechanical? So infiltration into the muscle causing restriction occur only in specific conditions when there is a specific infiltrative disease. Okay. It is not common in all diseases. In malignancies, you can get that. And there are certain other infiltrative diseases like myelodisis or there are some other diseases also where you can get infiltration of whatever lesion that into the muscle. So there the restriction of motility will be disproportionate to the proptosis. Even if the proptosis is mild, ocular restriction, movement restriction will be more. Secondaries, in orbital secondaries, it is quite common. You need not get a severe proptosis for the restriction. But restriction will be disproportionate. That is often in situations where it is due to infiltration. But if it is due to paralytic, if it is due to turnopalsy or apical tumors and all, you can get that. There will be a definite pattern. Which our movements are lost, you know that. It will be nerve-related or pattern. There will be a neurological pattern. But in other causes where there is a mechanical limitation due to a sweating or something, it is only mechanical. You can correlate that with the whatever mass or whatever proptosis you are seeing and the movement restriction. So all these can contribute to motility restriction. So when you see a patient with a motility restriction in a patient with proptosis, you should think what is causing that movement restriction here and why there is diplopia. Usually diplopia and all these patients may not come here unless it is severely interfering with the primary visual axis. So diplopia as a complaint usually you see in thyroid orbitopathy. In other cases, NSOID and all, they will have more other symptoms. So diplopia is as a primary symptom also is quite uncommon. And in this particular patient, your history says that there is diplopia. So again, that is also a little bit confusing to me. I'm not saying that it is not there. It may be there, but that is also a little bit not common with lymphoproliferate. Maybe because of the high grade thing, I don't know. That I have to read. I am not very sure about that. But even in high grade ones, I haven't seen that kind of muscle infiltration. But we can only explain the diplopia by saying that it is infiltrating into the muscle.
Yes, and lymphomas are known to infiltrate muscles as well.
Huh?
Lymphomas are known to infiltrate muscles.
They are known to or not to?
No, they can infiltrate.
They can. Maybe that is the reason. What about myositis? If it is myositis, what are the you were saying that as the diagnosis. If it is myositis causing the restriction, then how will you identify that in your MRI or in your imaging?
In myositis, if it is affecting the muscle, there will be enlargement of muscle as well as the tendon with the indistinct borders.
The whole of the muscle will be swollen,
Yes,
basal borders and all. So then only you can diagnose it as a myositis type. In thyroid, you will not get any.
Tendon enlargement, only muscle belly enlargement.
And which are the muscles that are commonly affected in thyroid eye disease?
Inferior rectus, medial rectus, superior, followed by
So usually it starts with inferior.
inferior rectus.
That is also not there. Can you get unilateral thyroid eye disease? Can you get unilateral thyroid disease?
Yes, madam.
So do you think, consider this in this particular case that is a diagnosis?
No, because
Why?
axial proptosis in thyroid usually present as axial proptosis.
And with your imaging and all, there is no mass.
Imaging there, there will not be any mass like this. Only muscle belly enlargement with a distinct varus, not tendon enlargement. Tendon sparing will be there.
That even though we know that thyroid orbitopathy is the most important cause and most common cause for proptosis, in this kind of an eccentric proptosis, we will not consider that. And when you're feeling a mass lesion, your diagnosis is going away from thyroid disease. Otherwise, when in adults, when you see a proptosis, you should always think about whether it is unilateral or bilateral. You should always think about thyroid eye disease as one of the causes. What are the tumors that you can get in children if it is with a similar kind of history and progression and
Rhabdomyosarcoma.
yes, that you have to always keep in mind. What are the other changes you will get in the periocular skin and all?
Madam, in rhabdomyosarcoma, general.
In children.
In children, periocular pigmentation.
Other than rhabdomyosarcoma, any other malignancy that can present like this? With an imaging like this? Any hemopoietic tumors?
Capillary hemangioma.
Capillary hemangioma is a different picture altogether. This kind of an imaging diffuse mass. Leukemias. In leukemias. So leukemic infiltration can also present like this. Just like lymphomas, any hemopoietic malignancies can present like this. Then you need not even do a biopsy. You can go for a pencil smear, and then if you retinal examination will reveal a lot of folds and other retinal picture suggestive of anemia. So then you may do a bone marrow or a peripheral smear, and then your diagnosis is done. So that is also something which you have to keep in mind. But in adults, AML and all producing a leukemic deposit in the orbit is quite rare. But that also should be a possibility in your differential diagnosis list, and if everything else is negative. Anything else? Yeah.
I think we have covered almost everything.
Okay, then it's almost. Sujata, are you there?
Yes.
Bastin? So Anu presented it very well. And the case is a little surprising for us with the correlation, whatever it is. It was a little bit of a surprise, but otherwise you did well. Ravija, do you have any comments?
Yes, nicely presented. All the examination points were very well covered.
We had very less questions for her. Austin, can we stop then?
Okay.
Austin. Okay.
Thank you, Dr. Ravija and Dr. Ina for the systematic, lucid discussion. And thank you, and Dr. Anu for the nice presentation. Thank you all.
Thank you.